Hey, Gestalt Education Nation. New sponsor alert. Today, we're excited to announce Dynamic Disc Designs and Jerome Fryer. We have an awesome discount code for you. Just use the code Gestalt to get a little bit of money off on the Dynamic Disc Designs. They're the most realistic anatomical discs that we've ever seen. If you caught our episode with Dr. Stuart McGill, you saw an entire shelf full of them. Everything from cavitation instruction to disc dysfunction to SI joint dysfunction, all sorts of amazing
joint
stuff.
movement,
Yes,
vertebral movement.
Absolutely. So go to Dynamic Disc Designs, use the code Gestalt. As always, you can use the code Gestalt on Core 360 belt to get a little discount on the belts there. We love to use that for biofeedback for teaching respiration, intra-abdominal pressure, and how the abdominal wall should be working during function. And then the last one, use the code Gestalt Education 10. Those will all be in the description in the podcast. Gestalt Education 10 at humanlocomotion.com to get off some money off of all of his awesome gadgets and tools and rehab materials. What's your favorite, Brett?
He's got a trunk full, but I think, integrating the Toe Pro, and I think, has been a game changer for us here at the office. So I think that would be my pick.
Beautiful. All right, guys, don't forget, use the code Gestalt, Gestalt Education 10. Visit the show notes and you'll be hooked up. Thanks. Enjoy the episode. All right, everyone. Welcome to another episode of the Gestalt Education Show. Today we are in Kansas City, at Overland Park, Kansas, technically, at the Super Bowl of Adjusting weekend. So
big weekend, bud.
This
big
is
weekend.
big weekend.
Colossal.
This is one that just gets circled, highlighted, stickers, glitter around the calendar every single year.
The only excuse is if you are getting married that weekend, then no other excuse counts. You just show up here. That's just the way that it is.
That's right. So we've been waiting for this for a long time.
This has been COVID. You're locked in Canada for like 8 years.
Our favorite manipulator from north of the border, the one and only Sarah Macchi. So, Sarah, you have a reputation for not being the largest female on planet Earth. I know it's kind of crazy, right? But you also have the reputation for not being afraid to take on some of the biggest people when it comes to manipulation. And so the story that I always tell is one of our good buddies, Steve Bird, he's a large human being. He is just he is a large human being. So to make a point, you brought him up on the stage at Adjust-a-thon. It was probably 3 or 4 years ago now, and just absolutely nuked his SI joint. And the point that you were making is that if your setup is good, and if you take the time to be good at those types of things, then you can move basically anybody on this planet. And so have you always had a little bit of a chip on your shoulder when it comes to that? Or, I know Brett and Corey have told stories about you guys all pushing each other, but I don't know, can you just kind of talk about your philosophy maybe when it comes to adjusting patients? It doesn't have to be bigger than you or just patients in general.
I don't know I guess I would start by saying even just entering chiropractic college, there was always I'd been to a chiropractor, but always the question, but I think a lot of people have this, can I do this? Like, can I, not just the physical part, but can I get through the studies? And then you get through the studies and then you start to realize what's actually involved with doing adjustments. And, I would say the schools teach us things and some useful and some that you just need to kind of adapt. So when I wandered into motion palpation, thank God, first week of T1, and saw what was happening with the instructor, the leader of the club there. I realized it was Joel Johnston.
Oh, yeah.
Like life-changing, definitely set me on a path. So I guess I don't want to lose your point, but have I always had a chip on my shoulder? I always wondered, am I going to be able to do this? But only after I saw, oh, okay, this is what's happening, because I started to watch these docs. And I thankfully had good mentors, good influence. I do remember Dr. Elder saying to me right from first seminar, don't ever let anyone tell you you can't do this. Mm-hmm. But the truth of the matter is you're going to have to work harder. You do have to work harder. My margin for error is very slim. I have to be better. I have to be more precise with how I do things. So I've never been one to be cocky, because I think there's right around the corner, there's going to be someone better than you. So I don't really like the, you're the best at this or best at that. But at the same time, it's like I have worked my butt off. I don't think I am the best at it, but I do my best. And I try to follow the rules that have been given and make it work for me. So yes, I guess to answer the question, I don't know if it's a chip on my shoulder, but always a little bit of secret doubt. But then like, no, heck, I can do this. Yeah. I just have to work harder. I have to practice harder. So
I think too, I mean, like Newton's second law, force equals mass times acceleration. If you haven't been gifted with mass, then you've got to make up for that with acceleration. So what you'll find is anybody who is a smaller statured doc, and if they're really good at it, you'll see they're going to have to accelerate and be quicker because they're not going to be able to get away with just like rolling underneath them and just falling on it. Yeah. So I think like that is one thing that the smaller docs, a good message is like, unfortunately, you got to roll with the oars you're born with, but then there's a way to get around it. And then the extremity joints, then you can't rely on your mass there anyway. Yes. So I mean, at some point you got to learn how to be fast anyways. But I think like, what you're so good at, you're so good at creating a lot of acceleration and speed in a really tight amount of space.
Over a really short period of time.
Yeah, exactly.
Like be fast, quickly, if that makes sense. Over, and I think where you can do that is when your setup is right, when the equipment is right. I always preach, I don't wear high heels, but I have to wear a wedge. Like I can't be tall enough. I'm 5 foot 3/4 of an inch. So, and there will be limitations. Everyone's going to have limitations, but I want to minimize the limitations as much as I can and optimize the setting for the patient and me to do the best thrust impulse drop that I can. So yeah, and there's tricks with that, and some of it, like I had great teachers, but I think, like I always say someone said, and I love, necessity is the mother of invention. And when I'm alone in my treatment room and I've been taught all the best things, what's going to work for me? So, I've found the perfect adjusting table. And if they ever stop making it, I have to retire or find another career because I don't know if I can do it. So I have to have the right equipment to give me the best chance. So that's.
I think, unfortunately, too, don't you think like 20 years ago, like as far as adjusting, and this is horrible that it was like that, but it was kind of a man's world a little bit. And I feel like, what people used to say is Sarah's the best female adjuster in the world. And no one says that anymore. Everybody says Sarah's the best adjuster in the world, So can you talk about like kind of, I don't know, maybe the obstacles or the struggles with being great at manipulation, being a female?
Oh, being great, being female.
I mean, you have the size thing, but there's other.
I think, I don't know if I'm going to answer. Like, I think being a little bit athletic. I mean, I grew up I was a gymnast. I was a personal trainer and aerobics instructor. Then I wrestled in university. I love to run. So I think having a bit of a body type that you're not afraid to get into positions. When you get pretty up close and personal when you're on the wrestling mat with someone. So you've got to get close and be comfortable in that adjusting space. So, and then, I think there is a bit of a stigma, or like, I mean, I have patients come into my office every day, and I'm sure there's times where, and maybe I felt this way more when I first got out into practice, that someone's going to hear my name and say, oh, I don't want to see a female chiropractor, so I'll schedule with the other doctor. I would say that there are, like, we do all online booking. People book themselves in, and sometimes big men walk in and they have chosen to see me for whatever reason, which I like that. And even when I'm teaching, I think that I can teach someone who's bigger than me, who doesn't have the same body type, just like Dr. Elder taught me how to do pelvic adjusting. He's not a small female. Sure ain't a small female. No. But I think, there's probably a little bit of that. I think as I've been in practice longer, I have less of that, because it's like you're coming to me as a professional, and just you're assuming my skills are decent. But I do think there is that sort of, is she going to be able to get the job done? And I've had patients say, oh, you're pretty small. It doesn't happen often, but nothing like the beast inside me grows when someone says, you're pretty small. Are you going to be able? It's like,
nostrils flaring.
But I think less and less, and I do. But I'm sure that's out there, and to each his own.
Well, and I think like you guys are probably, I'd like to hear both of you talk about it. There's certain principles of manipulation and palpation that help us all to succeed. Mm-hmm. But what do you think, like early on, I guess, what were some of the things that you were doing that were allowing you to work on that quickness, or allowing you to kind of get that concept in your brain that I've got to be quick in this little tiny space? So, like what were some of the things that you were working on? And then maybe what are some of the principles that you still carry with you today? Okay.
So I think I'm going to say the same thing again, is set the stage. It's the equipment, the positioning, all of that. Once all of that is good, because if that's not good, as fast as I can be, as big as I am, good things probably aren't going to happen. So I think having everything so that you can be as relaxed as possible. If I've got someone in the chair and they're high, and I've got their head like this, I'm scrunched up, I'm going to be tight, I can't be fast. So again, getting them to bringing the patient to where they can be relaxed, and most importantly, I can be relaxed so that I can be fast. Working on speed drills, like I don't know if you're kind of going that way with, which we'll talk about this weekend, but like doing your setups and your body drop drills, like just getting grooving those patterns so that you can deliver that force
And like, I know, Brett, you love the free motion. You like the feeling of the free motion, work on like your cervical. For me, it was TheraBands. Like I felt like TheraBands were really, I liked that feeling.
Didn't have TheraBands when I was in school. And no, I'm teasing. But, theirs is a new thing. But that is probably one of my, we used to use a speeder board. And we would just hold the speeder board and then thrust into the speeder board. Myself, my roommates, we there's a little hook on the back and we hung it sort of between this little piece of wall on the way to the washroom. And, it was 10 thrusts on your way in and then 10 thrusts on your way out. So it's not ideal because it ends. Whereas, you want to go through the joint. You don't want to be stopped by a block. So I think the TheraBands and just kind of, instead of even pulling it from an attachment point, kind of have it built in intrinsically. So you are actually feeling, just like when you do the supportive hand contact, you're feeling some of that feed into that. So TheraBands and those types of things. We used to do silly things like standing on a wobble board with our back foot or our front foot and then our other leg up in the air on body drops. Because if you can practice and take away all your support and stability and have to rely on your own intrinsic stability to deliver, to drop, imagine what happens when you get down on solid ground and you're allowed to make contact with your back leg. So a lot of little drills like that.
Perfect.
Yeah.
I think too, all of us who've been doing it for a while, at some point you get good at the psychomotor skill. Mm-hmm. And then you have this weird moment when for me, it was like, I was probably like 3 years out where I was like, I'm good at the adjusting, but I need to get better at the palpation. Yeah. Did you have that moment in your journey?
Yeah. Oh, maybe slightly off from that. It's like, we were all about obviously the junctional areas and the pelvis. And I would say I did not take enough time to learn about the hip. The hip's kind of a big deal. And so once you get out in practice and you're humbled by, wow, this is not, maybe it was my palpation, but maybe it's not an SI joint issue. Maybe I need to be given more time to the hip. Or I just don't feel very confident there, so I'm just going to avoid the TL junction. And it actually was, I think, the first Adjust-a-thon that I attended before I was teaching, and you showed that sideline palpation. Mm-hmm. And that changed everything when you actually slow down to feel, and your batting averages, I'm using the wrong analogy with these guys, but it just goes way up when you actually go, I do feel that restriction, and taking the time to actually get good at that palpation. Mm-hmm. And I would say, I had things to learn, definitely, and always still do. But I think that's correct, because it's easy when you have that psychomotor skill, like you said, to just go, okay, you know what? It's the end of the day. I'm just going to do a drop and something's going to happen. Mm-hmm. But really forcing yourself to say, on this patient, I need to figure out exactly what I'm going to do. So,
well, and I think that plays into your idea of like your success, like having success in big situations, whether that's with someone bigger than you, whether it's with a professional athlete or someone big in your town, is like being able to have that, second nature of, I know that this is restricted. Yeah. Like this, I know that this is a key link. Yeah. Can you guys talk maybe about that development? I know we're kind of on the palpation thing, but Brett, maybe I know end range has been a big epiphany moment for you in the last 5 years or so. Yeah. Any other thoughts on that?
I think that that was for those of you who don't know, I tell the story a lot now about, I was in the basement of Logan, we were teaching adjusting, and one of the students was like, I'm just not feeling it. And like what I watched them, I'm like, well, that's not what I showed. So like what they were doing was they were from a seated scam position and they were just kind of jiggling the SI joint. And then I was like, well, that's not what I did. So then I did it myself again. I'm like, oh, what I'm doing, I'm taking all the motion out in the plane of motion that I'm trying to palpate for. And then I'm springing. That's what's making it easy for me to feel. So what I was doing was not what I was teaching. So then I start playing around. I'm like, well, I wonder if this is true like everywhere in the body. And like literally it kept me up for a week. And I'm like, this is exactly what is missing.
Yeah. Well, and the reason I love that story is I kind of wanted you to talk about that as well. I have to imagine that has to help you. Getting things at end range allows you to feel it better, but it also allows you to kind of deal with a lot of mass in a little short area.
Yeah. And sort of thinking about like trying to isolate as best you can. Like we talk about specificity, and we know that we can only, the joint can only do what it can do. You impart a thrust or a drop and things happen. We can only control, what happens on the exterior once it goes through that sort of muscle fat joint interface. Like who knows what happens in there, but trying to create the scenario where at least where what tissue or what joint you're localizing your force to, and creating that end range there. And I think that's like you talk a lot about that. The end range, getting the restriction, getting that joint that's restricted to its end range without locking everything out. Its end range is happening at a segment or a joint, but lockout happens to everything around it.
That's a good point.
And I think of like, when you're around a group of docs, you see that and that's why I think everyone has this tendency to want to induce more rotation, because that's going to give you that tension that you feel. But if you've built the foundation and put the house on it and pack everything in, I think that's the end range we want without making the patient feel vulnerable to, oh God, what's going to happen?
I think too, the other reason, like, and we were guilty, I was guilty of this teaching early on, is like, we kind of like said there was two camps, like we're talking about the low back, like you have your, the anterior pelvic tilt and you have the posterior pelvic tilt. Well, then once I started getting better at palpation, I realized that like you can be in a global anterior pelvic tilt and actually still have an extension restriction.
Absolutely, yeah.
And like, so I was wrong in teaching that anybody who was like this, we have to flex them or we got to counter nutate them. But like, if you're not palpating in range, you would never like get to that point.
And I think we don't have the luxury of having algorithms. I wish that a patient sat down and we could go, if this, then this, if this, go here. Right. That's not manipulation, because every patient is different. And yes, we more or less palpate similarly and adjust similarly. But I think that you want rules. People want to have, so then you say, if you see, as Dr. Elder talks about the J-Lo or the plumber, if you have this extension, then they need counter nutation. Well, no, not necessarily. You have to palpate. But if you're not thinking in a movement-based, functionally based, you're going to just draw those conclusions. So and go for a more extension. So
or just because you're J-Lo, that doesn't mean you're blocked into counter nutation. It might just, you could be hypermobile in the counter nutation.
Exactly, yeah.
The other thing too, like even in the McKinsey world, like there's a certain group of patients who needs to be mulligan belted at L5S1. So like they may be globally in like this anterior pelvic tilt, but we're still going to clean out their restriction and derangement with a press up, because they're doing a press up. L5S1 is staying very neutral and they got what we call like a high hinge. But if we belt them, totally different if we get the motion right here and then we blow them up into nutation, which goes against exactly what I was kind of taught to do when I was young. Like you would never nutate a J-Lo basically.
Right.
So like it just depends. Again, I mean, you can start to have some ideas about what you might be doing, but your eyes can trick you. But a lot of times your hands will not trick you.
Exactly.
Yeah.
Well, I think it's combining everything together. You told the story of the research that was done on whether or not we can feel restrictions. They took PTs from Canada, right? PTs, chiros off the street, and they were bad at feeling nuances, but they were great at feeling big joint blockages, which is probably where a lot of these students are at right now. We would argue that the better you get at this, the more time you have under clinical experience, the more you're able to feel those nuances. And so that would be an example of a nuance. You may not have joints at end range and be just kind of prodding along and think, oh, well, they're sloppy in their low back. They don't need their low back adjusted. And you might be missing one of those huge joint blockages or like the big key links.
Yeah, I mean, Kowalczuk's paper exposed that. It said like even, they didn't say how well these chiros or PTs have been trained, but let's just say not very well. But they actually, the conclusion of the paper was we're not good at palpating subtleties. Okay. But like actually they were good at finding massive blockages of joints. And that goes back to Lynn's original model, which was maybe you want to be staying away from the subtleties anyways. Like you want to be creating
are they
motion at
clinically
these-
relevant?
Yeah, exactly.
Is it clinically relevant? And I always think, well, no one comes in after I've done a palpation, after I've palpated my patient and adjusted them, or I don't bring another doc in to say, hey, what do you think? I'm treating the patient, I'm palpating. But if I am identifying to me what is the stiffest spinal segment, and it has a clinical purpose for this patient and the outcome is positive, and I also don't have a stiffness measuring device in my office. So there are certain limitations. I'm not saying that we shouldn't keep trying to study and learn, but I think, you could detect up to a certain level based on these inflatable targets, but then you got to this really tiny range and we couldn't feel it. It's like, yeah, but still, like maybe I'm looking for the biggest, stiffest, so area that needs adjusting.
It's always funny too, because we always talk about N equals 1 with our patients, but why can't N equal 1 with our doctors too? Yeah. Like there's so much built into me versus Sarah versus Brett, are the way that we think, the way that we view different things, and as long as clinical outcomes are coming along, we're doing the best we can to feel these subtleties, to feel these big key links and go after them. I mean, that's why it's called practice, right? Like you're just making clinical leaps, and I think that's what comes with experience. I don't know if you can.
Well, the other thing too, like as a student, you think if you can adjust like Sarah, then you just have miracle after miracle after miracle. Yeah. So like we're in a really unique profession where you can literally be the best in the world at manipulation, and you may or may not get your patients better today. Like, so there's so much that are involved. And I think as a student, you're just led to believe if I can adjust well, then I'm going to be, getting these positive outcomes. There's so much to.
You've got that tool dialed. Yeah. Now bring in the other,
Right.
Yeah.
But I mean, that's what's like, this is why, and I think that's why like.
Sorry to interrupt your episode, guys. I have to tell you about an important date to write down in your calendar, November 3rd through the 5th, the first annual Neurodynamics World Congress coming to you at Parker University in Dallas, Texas, November 3rd through the 5th. This is an amazing opportunity to see a true Gestalt weekend, meaning integration of multiple different people, multiple different techniques of the likes of Michael Leahy, Antonio Stecco, Brett Winchester talking about DNS, Annie O'Connor talking about pain classification mechanisms, David Seaming talking about the internal chemistry, Jeff Bove talking about the research around nerves, and of course Michael Shacklock talking about neurodynamics. This weekend at Parker University, November 3rd through the 5th is your opportunity to see not only lectures, but hands-on demonstrations and panel discussions at the end of every day to combine this all together to show how each of these different techniques is influencing the nervous system. This is an amazing opportunity to see all these people in one stage and one opportunity to have some fun with us in Gestalt education. So thanks for taking the time to listen to this episode, and we can't wait to see you at Parker University. It's November 3rd through the 5th. Registration open at gestaltedu.com/courses. See you there.
The three of us and others, like we're just almost enamored with the profession just because like it is like such a challenge. Like, like if you're a professional athlete, let's say baseball, you're good at hitting well, you're going to get rewarded financially for it. Like our profession is so different in that like, just because you're great at adjusting doesn't even mean you're going to get people better. And it actually doesn't even mean that you're going to make money doing it. It's like kind of a really weird, twisted.
Yeah, you see it all the time.
Yeah.
It's like, why isn't that person more, whatever success is to you, but why isn't that like, you hear about a student that was so great and then you hear that they've either left the profession or it's like, how did that happen?
Right.
So.
Right. Well, maybe can we switch gears a little bit? Brett, you opened up your lecture today too, talking about audits. We talked about that at the rep meeting yesterday. Sarah, could you kind of take us through your clinical audit process? What's your hierarchy, as far as trigger points versus range of motion versus palpation versus movement?
I just ask the patients if they're feeling better. My first question is, how are you feeling today?
Yeah, right.
So I would have to say Brett really instilled that, the palpate, adjust, treat, repalpate. I do a lot more of that now thanks to Brett. So yes, I always adjust or palpate, adjust, and recheck. But I also do a fair amount of DNS. Like I would say I would be lost without DNS and in my practice. So I think a lot of times watching someone, I will use the functional screens like the DNS tests. I think those are great because patients can feel them. They know how they failed. And I'm always surprised, even if it's like, next visit, I want to recheck a couple things were positive a couple weeks ago. And I'm always surprised because I've made the notes, but patients remember how they performed it, which is interesting. It's like, oh my God, I used to to really hinge. So I do. I would say those are the two biggest things. And yeah, of course, I want to know how people are feeling. But yeah, it's I would say those would be the two biggest ways.
What else? I mean, obviously we know, but they might not know. What are the things you're combining in practice? We obviously talked about MPI and then DNS. What else what's in your tool?
So ART and Graston. Those it's kind of like when we were in school, all there was MPI. So that's all I did all through school. And I think I did one little afternoon, maybe 3 hours. Mike Leahy came and did like a demo of ART, and that was it. And he showed us 3 protocols. And after that, after graduation, it was 2 years before I took any other continuing ed, which was Graston and then ART. And then came the DNS and the SFMA and now the Neurodynamics. And, and I've got a list of where I want to go, but yeah, I think initially, and that probably served, not to get back on the palpating adjustment, but I think that's what served us so well is that was our only tool. And we just threw ourselves into it because we didn't have a lot of distractions.
That's what I was going to, so do you think it's kind of not a mistake, but like our new contemporary student, they're like there's so many things that are vying for their attention that sometimes the adjustment kind of gets overlooked.
Yeah, especially because it's hard to learn how to palpate and to adjust. And so people toss it away because they don't take the time to get good at it. And then they feel like they can be clinically effective with something else, which you need other tools. And I do a ton of extremities. Like I would say I adjust every day. I adjust feet and hips every day or mobilize using the speeder board. I do ART every day. I do Graston every week. I do Neurodynamics daily. I do DNS daily. Like there's, you've got all of that. So, but yeah, I think there's so much coming at students. And if you're not going to be proficient at something, never mind. As a student, I'd say the good thing is that you can take a course and you can get a discount on it. So do it while you're a student, but at the same time, you don't have any patience to use it on. So your proficiency really doesn't happen. And then it's sort of kind of lost.
What is Sarah's gold medal move? Someday when you're dead and gone, well, they'll look back and say Sarah was like the best at what move do you think? What move do you think you're the best at?
Oh, man.
I have my idea. I'll be curious to hear what you say.
I kind of light up, I think, when I teach kicks and drops. But I think we all like the seated CT move because it doesn't get done a lot and it's a big area of the spine to do. But I'm going to say it's probably a body drop. Okay?
Yeah, nutation body drops. What I would probably say, like when you're.
Yeah, SI nutation. Yeah, I would say.
Yeah, did SI joint this morning. It was awesome, of course. So that's always good. Can you maybe both of you give a little pep talk to the students that maybe listen to this, or the people that are 5 years out, under 5 years, and can you just tell us like the importance of palpation again? How to get better at palpation too? Like how during your day seeing patients, how are you getting better with palpation?
Yeah, I think for all of this, you have to work harder than you think you do. You have to spend more time than you think you do. I think if you're used to things coming easily to you, because I would say I'm not, I didn't have that intuition or that tissue sense. I think, other people in my class or other MPI people, they got it before I did. And I think sometimes, the harder you have to work for something, the better you learn it, the better you become at teaching it. So I think, a lot more repetition, and grab any free body, any chance you get, and palpate. And, I think that's and spend way more time than you think you have to.
I think I learned so much when I thought that I was feeling joint blockage. I went to thrust on it. And when I was thrusting, I felt that actually the joint was moving well. And then at that point, then I took a step back, went back to the original palpation and tried to have a learning moment to say like what I miss. I think like that is like where I had the best learning moments in palpation was that when I thought something was restricted, but then when I went to thrust on, I could feel things moving underneath my hands. And I'm like, oh, it's not like these patients are worse per se, but you're obviously, if you're thrusting on, it's already moving, then that kind of defeats the purpose. So I think that helped me out a lot. And then the other thing would be like we were talking about with the end range, and then being able to decipher soft tissue restriction from joint blockage, I think is like grossly understated. And actually, James Syriac's talked about this quite a bit, where I just said bitch, quite a bit. Quite a bit.
Now I got to put the explicit on this episode. So thanks.
Anyways. where he talked about the importance of being able to decipher between like when the soft tissues are getting in the way. And I think this is a really, really important point that I just talked about in the docs only meeting, which was like some of the moves that as people age, you no longer like to do with your patients. It's because they're so tight in their soft tissues that you're not getting the in range. For example, the MPI move, occiput move, like we love doing it on our young, healthy students because like there's all that freedom to get them to end range. Well, once you're 80 years old, like they're like here.
She's not so compliant.
So all of a sudden you're like, well, all of a sudden I'm loving this occipital lip, but I don't know why. And the reason is because like when you go to do this, they don't have the lateral flexion. So therefore it's not in range. Therefore it's not cavitating and moving the way that you want.
Yeah.
So I would say like but I mean, I said it this morning and for what it's worth, I believe this to be true. The great adjuster in the world that is not good at palpation, doesn't exist. Like it is 100% coupled together. Like if you don't know how to palpate and you don't know anatomy, you cannot be great at adjusting.
True. A common theme, Sarah, which we've asked everyone from PTs to orthopedic surgeons to all this thing is around palpation. It's like a crusade of Brett and I's to get people to not believe the noise saying that you can't palpate. Mm-hmm. So could you just speak on that? I know we're hammering home palpation right now, but what do you say to the students that say, oh, well, people are telling me that I can't palpate and I can't feel it and I can't do that?
No one can tell you what you feel. You adjust based on what you feel. You've got to be certain and have that confidence in your skills, in what you feel. And ultimately you're the one who's delivering the thrust or not, if you don't think you need. And I think we all we always say preaching to the choir in a group like this, maybe not everyone that's learning, but we all palpate the same way. Like if you said palpate my occiput, we may have little nuances, but we're all doing the same thing. So standardization amongst us is going to be really, really good. And when we were at seminars and when I was a student, we were always doing the inter-examiner reliability test. Okay, you palpate. Don't tell me what you found. Okay, now you come. And lo and behold, that's not an official study, and I'm not saying like I'm all for the research, but at the same time, I can't just stare at my patient and pound down high spots or say it hurts here. Okay, well then I'm going to adjust you there. So I think that within the MPI family, all of us, not just the docs, but everyone who's done this coming up through school, we're palpating differently than a lot of the studies are. It's usually probably a prone thoracic, and it's someone who does it differently. But if we all kind of palpate the same way and we're feeling for the same things, like I feel like there can be consistency. And I forget your question now. So
So I think too, like the anatomy sometimes determines what's easy and what's hard. Like for example, the SI joint. Maybe one of the easier, adjustments that we do, but for everybody getting an agreement whether or not the SI joint's blocked, it's a little bit harder because the SI joint moves so uniquely. I mean, it's basically moving it's jiggling and there's like hardly any motion there. So whereas the lumbar spine, lay inside posture and spring the joint, I mean, you couldn't miss it if you tried. Yeah. So I think sometimes people just think, well, once you learn how to joint play one joint, it's like every joint, because of the anatomy, has its unique feeling that you have to get good at. And that's what makes it, I think, the palpation so hard.
Yeah. Every joint on every patient is like you have you would say the hypermobile patient where it's like, oh, they don't need anything. No, they've got restrictions kind of sprinkled in amongst their really hypermobile spine. It's like, I got to get that joint. I got to feel what's happening there and then set that patient up in a totally different way to make something happen there. But I think, not just different joints, different regions, different patients. And once you get into practice, it's like you can do that palpation on someone, but there's so many other factors you have to control for to really get to that point. Right. So the joints are different, the patients are different. You're going to feel so many. Yeah, there's a lot of.
So we said what your gold medal move is. If we followed you for a day, what is the move that you're doing most often, would you say? Because that's going to tell us the joint blockage that you're probably feeling the most in.
Lower T-spine, upper T-spine. Yeah.
Mm-hmm.
Yeah, I think when you're around people who you trust their opinion, I think the thing that everybody comes back to, it's man, the thoracolumbar junction and the CT junction, those two areas are and I think honestly, and even the docs, I think thought I was crazy down there a second ago, the upper cervical spine, it's there. Mm-hmm. But I feel once you get good at joint play, you're going to be adjusting that. And that's probably a good thing because then we're not putting the patient at risk for vertebral artery and carotid artery. So maybe that's a blessing. But I think that you'll find that there is actually less blockages in the upper cervical spine than you ever thought. I literally thought that I'd be adjusting everybody's occiput bilaterally. And I've kind of learned as time's gone on, it's like, well, now that I know how to joint play, now I know how to decipher soft tissue restriction. And that can be easily done by just putting the patient on their back to palpate, which that's a good question for you. Like early on, like when we were both teaching a bunch early on, like it was like a badge of honor to be able to do everything seated. Like it was almost like we were known in MPI for seated. Yeah. We've kind of backed off that, which I think is a good thing. What's your thoughts on that?
Yeah. Obviously by and large, most people do supine, right? If a patient is more comfortable, I will. I still would say if I'm going to choose to do it in the chair, but if I can't get the job done, absolutely, I'm going to do it. If I'm really convinced that's what I need to do. But again, I would say probably for, if I'm spending the majority of my time in upper and lower thoracics, I'm doing that mostly anterior. I get as high as I can in the CT junction. I get as low as I can in the TL. When I can't get high enough, then it's a prone thumb or seated, or if it's a side posture. So but I do think you can't throw the baby out with the bathwater. The one thing I will say, I don't remember the last time I did was a prone thoracic in practice. That would be the one thing. But occasionally, and I can think of 2 patients right now that I would do a supine cervical, but again, you do what you got to do, or you go to the flexion occiput, whether we call it an adjustment or soft tissue release or immobilization. I mean, if you think about it, that one actually feels so good to have done that it's not what we gravitate to because it's not as fun, but it's clinically a very good move. So yeah.
It's like I think we hit that home as far as today, like we liberate yourself as a clinician and don't always have cavitation as the main goal. Like the goal we know with adjusting, the goal is to improve stiffness and I think like unfortunately, especially when you're a student, like success is solely on whether or not a joint cavitated, and some joints are cavitated, some won't. If you're working with an 80-year-old patient that has a stiff thoracic spine, it may literally take you 2 months before you can start to loosen that up to where it will actually start to release, and that in itself is an audit. At some point that case will turn and you will start to be able to release that joint. And that's a great moment where the patient were like, that actually released today, but that doesn't mean that the 2 months before were wasted. It was setting you up for that moment when you were able to get the joint to release.
That's something I stole from Brett all day long. Like all day long, you're educating your patient. Like, do you remember how hard I had to work to get these things to release? Like now it's just like butter. Yeah. So I think it's another good audit process and communication. As we're kind of wrapping up here, Sarah, you've been doing this for a while. You and Brett are seasoned vets. What are some things that you do outside of clinic that help you keep your mind right? You're seeing a lot of patients. You're traveling to teach, things like that. What are some of the things that you take care of yourself as far as mentally, physically, things like that keep you healthy in practice? Yes,
I love to run. And I live in the mountains, so I can get out my door, and I like to walk to work. I'm about a maybe 9 or 10 minute walk to work, and that I find that's awesome because a lot of days I'm like, hey Tom, I'm going to walk to work. You drive if you want. And that helps me clear my mind. I do. I love to run and get out in the outdoors and just be kind of forget things because I can be a little busy in my brain. For people who know me, I meditate. I do. I fall off the wagon once in a while, but I do. I do some. I try to do a little meditation, yeah, I'm not actually super social. I need recharge time. So I love these kind of events, and you guys are great and all, but I kind of need a little step back. Yeah, I'm a loner. I'm a lone wolf. Actually. Yeah.
There's nothing wrong with that. I think it's just recognizing, I think I'm 5.5 years in now. And so trying to recognize what you actually need to recharge, because what you think you need and what you actually need sometimes are a little bit different.
Oh, for sure.
I think understanding that's really important. So, well, Sarah, I mean, you are the best adjuster on the planet. You're here for a reason. Every September, this is just a no-brainer to come because you get to see awesome people like yourself. Lindsay, Muma, Erica, Brett, Mark, Lynn was here this weekend,
Corey,
Terry,
Lynn.
Corey. I mean, it's just such an awesome weekend. And there's not a lot of sleep that happens this weekend because there's too much socializing, but that's a good thing. And I'm just thankful for your education of me. Brett, obviously, is always a mentor, but we're just always thankful for you being out here. You talked about before we got on that you don't love doing these things. You don't love teaching and things like that.
It shows. I think it shows.
No, you did amazing. But we're us as an MPI family, we're thankful of you.
Thank you. Yeah, these weekends, I think we kind of push each other. Like being around good people, great adjusters makes me want to be even better. I always feel like a better chiropractor when I get back in practice after these weekends. So it's a little self-serving in that regard. So
absolutely.
Thank you guys.
Even if you've been doing this for 20 years, you catch one thing, like that is such that energizes you and you should be here. And one thing we should mention is new with this year's Motion Palpation Institute Adjust-a-thon is a DC track. And so there's a separate area in the student clinic here at Cleveland where the docs, the DCs are there. The instructors are cycling through. Brett, can you maybe just talk on what the purpose of that is and kind of what they're learning different from the students?
We felt like at the MPI seminars or the Adjust-a-thon that the doctors sometimes they would come and they were amongst a bunch of students and, it just kind of was like, they've been at it for a while. So they had questions that didn't really pertain to like what we were teaching. So we thought that, it'd be decent if we could separate them and we'd still have our socials together and maybe like an opening lecture. But besides that, we're down there talking about advanced topics. Like you just heard me talk. I could never in a million years talk about that in that setting because like if you're a try 1 through try 3, you don't even know how to body drop, I think it's really kind of going to be the future and really what the goal is. We want everybody to mark their calendar. The last weekend in September is when you come for us all to hang out and not just the students, but also the docs because you never can get too good at manipulation. You're never that good. And I guess the other thing I would say is, I don't know why this is, like the most important tool you have, you never come to another MPI seminar after you graduate. Think how insane that is. Yeah. So we're trying to expose all that, and then we're all learning together. So it's not like just because you're a doc that you should feel less of yourself because you want to get better. No, we're all on this journey or crusade to be better. So. Yeah.
That's why selfishly for you guys, you get to teach on a weekend. How much better do you get after a weekend of teaching?
Oh gosh. So
there's always someone pushing the limits, and you should always be a little bit. I always am a little bit uncomfortable of like, well, I can't let Brett be. I got to chase what Brett's been doing, or my classmates and stuff. So I think healthy competition is what makes us all awesome. That's what made you two awesome. That's why you have such a good friendship because you were pushing each other in school. So I think that should be striving for all of us docs out there. Rock and roll.
Perfect.
Thank you so much. Appreciate you, Sarah.
Yeah,
Have a great day, guys. Good luck with patients. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.